يعود علينا وعليكم الأيام بكل صحة وعافية إن شاء الله. والنهاردة we'll discuss some of the musculoskeletal cases to review what have been studied during the last month. And actually, you know that every time the system is expanding because there are some of the new topics and some of the old topics that have been renewed, and they actually added in the schedule for the diploma online. Then we will have some of the cases that may reflect the most of the topics that have been studied. This is the case number one, and you can see here that we have an MRI of the shoulder with
Excuse me دكتور ممدوح.
نعم
احنا شايفين الشاشة على يعني الديسكتوب بتاع حضرتك، يعني مش شايفين البرزنتيشن نفسها.
فعلا.
يا دكتور مش شايفين البرزنتيشن.
طب ثانية واحدة، معلش ممكن
حضرتك تعمل ستوب شير وتعمل شير تاني.
اوكي، ستوب شير وبعدين شير تاني وبعدين كده. شفتوا السكرين؟
تمام كده تمام.
كده شايفين الحالة يعني؟
يا دكتور
تمام. حضرتك ممكن تعملها بس فول سكرين وتبدأ تسجيل.
اوكي طيب تمام. يبقى احنا دلوقتي عندنا this is the MRI of the shoulder, and you see that is the gradient image. The shoulder joint is distended by fluid, and so many let's say loose bodies or low signal lesions. Then what do you think of this case?
Synovial osteochondromatosis.
Yes, and the first possibility is synovial osteochondromatosis, but we know that there is a similar lesion which may produce such an appearance, which is
rheumatoid arthritis.
Yes, rheumatoid arthritis with rice bodies, but the difference is in the clinical picture of the patient and also the size of the loose bodies. The rice bodies are of extreme uniform in size, and they are smaller, much smaller than these. Then we are dealing with the case of synovial osteochondromatosis. The second case is a hip joint with, as you can see, that the femoral head is collapsed and the joint space is widened, and there is some sclerotic reaction in the femoral head and the neck. What do you think?
Septic arthritis or osteopathy according to the history?
Okay. Then septic arthritis is a very good possibility, and it was a case of septic arthritis, but I also want you not to diagnose such a case as a vascular necrosis of the femoral head, because the changes are not in the femoral head only, but the changes are also in the acetabulum. And this means that this is an arthritic lesion, not a bony lesion. For the hip arthropathy, this is a disease which can be diagnosed when we have two follow-up studies, and we can see the extensive destructive changes in the femoral head in the follow-up study. And here you see an MRI of the ankle, axial image, and a coronal sagittal image. And you can see that the Achilles tendon is relatively swollen, and you got abnormal signal inside the
Haglund,
tendon.
Haglund syndrome.
Haglund syndrome. The Haglund ones needs three findings, and there should be some fluid in the retrocalcanean bursa, and also some fluid in the subcutaneous space. But here you see a bright signal inside the tendon itself, and there is some intact fibers superficially and deep. This may represent that the tendon is partially torn, or you got Achilles tendonitis or tendon degenerative changes. For Haglund syndrome, you need some fluid anterior and posterior to the Achilles tendon. And this is an MRI of the pelvis T2 weighted image.
Iliopsoas bursa.
Yes, and this is an iliopsoas bursitis. You know that the iliopsoas bursa can contain fluid by one of two ways. Number one, it may be inflamed. Number two is a fluid coming from the hip joint. Then, if you have a fluid in the hip joint and the fluid in the iliopsoas bursa, you think that both are related. But if you do not see fluid in the hip joint and you got fluid in the iliopsoas bursa, then this is iliopsoas bursitis. Then what do you think? This is an X-ray of the hand.
Psoriasis.
Psoriasis is one of the possibilities. Other
Scleroderma.
scleroderma, other suggestions.
Sarcoidosis. Sjogren.
Okay, you got
SLA.
that for scleroderma, you got erosions of the pharyngeal tufts and sometimes soft tissue calcification. For psoriasis, you got the penicillin cup appearance of the distal interphalangeal joint. But here you see one of the criteria of the distal.
Erosive.
Yes, and this is erosive osteoarthritis, which is and affects most of the joints in the distal interphalangeal space. Then here is an X-ray of the shoulder and also an MRI T1 weighted image of the shoulder.
Lipoma.
Yes, and we can diagnose actually lipoma even from the plain film by the relative radiolucency of the fat compared to the skeletal muscles. But whenever you have a CT or MRI, you are sure that this is fat, which is exactly of similar signal intensity to the subcutaneous fat. And if you have the fat suppressed sequence, then you got suppression of the fat signal. And this is an MRI of the foot T1 weighted image, and this is the vitamin E capsule, which is usually fixed to the site of pain for the patient.
Morton neuroma.
Yes, and this is very good in the Morton neuroma. And you remember that Morton neuroma is not a neuroma. It is just a proliferation of the tissue around the nerve because of the friction, and it has a classic appearance, which is the dumbbell configuration. And the most common site for Morton's neuroma is the third intertarsal space, and it may be also seen in the second space as well. Then it has a very characteristic site and appearance, being of low signal in the T1 and mostly of low signal in the T2. It will enhance with contrast material. Then this is a 9 years old female with multiple lesions. And you see a lesion in the ankle on the left side and also another one on the right side. and this lesion is in the humerus, and another lesion in the tibia. Then, in order to got the possible diagnosis, you have to differentiate first between neoplasm and infection. Do you think that these are neoplastic lesions or inflammatory?
The humerus look like infectious osteomyelitis.
Okay,
Apart
definitely
from
you should consider all as infection because you don't say that the patient had inflammation of the
Other lesion
humerus.
considered neoplastic, but
Sorry, what do you say?
other lesion I think it's neoplastic, but the humerus I don't know. يعني ischemic
This
sclerotic
lesion,
lesions.
this lesion you mean?
No.
Mm,
The humerus.
the humerus. The humerus is infection or tumor?
I think it's neoplastic.
Okay, which type of neoplasm in this age group?
It may be,
Mm,
but lymphoma, maybe lymphoma. But the
lymphoma.
age group even sarcoma, but even sarcoma if it's but even sarcoma is not multiple.
Yeah, no, this is not looks like Ewing sarcoma, of course, and you got some erosive changes in the humerus. There is no significant perosteal reaction around all lesions. Then the possibility of being an inflammatory condition should be is more likely than a neoplasm, because if you consider this as a lymphoma, and you should consider this as also lymphoma, and this one, but this does not fit well with the lymphoma possibility. Then you remember this new topic is included in the rest of the course. It is known as chronic recurrent multifocal osteomyelitis. If you diagnose this as an infection, then you consider all these lesions as infection. And the multifocal osteomyelitis is seen in two conditions. The first one is the sickle cell disease, and the second one is this one, which is the chromo or the chronic recurrent multifocal osteomyelitis. If the patient do not have the clinical features or the laboratory findings of sickle cell disease, then you consider these as the chromo, which is a more likely possibility than the sickle cell. What's chromo? It is a chronic recurrent multifocal osteomyelitis. It is an idiopathic inflammatory bone disorder seen in children and adolescents and is relatively common in females. The typical presentation is one of the sites that are very well demonstrated in this disease is the clavicle, and you got the clavicle involvement, which is expanded, and sometimes you got a periosteal reaction, and hence you may think of this if you see the clavicle. The most common sites other than the clavicle are the tibia, and if you have a biopsy from these lesions, you do not see organisms. And this is a classic appearance of what's known as chromo or chronic recurrent multifocal osteomyelitis. The typical locations are the metaphysis, symmetrical anterior chest wall, long tubular bones. The clavicle is one of the well-known sites. Then this is the case of MRI of the knee after ACL graft reconstruction.
Cyclops.
Cyclope lesion is present here in this particular area in the anterior knee joint space. But where is the graft?
Failed.
Failed, yes. And
The graft, yes.
you see a graft here, which should be of more or
Thank.
less similar to the posterior cruciate ligament, but the graft is not present. It is replaced by fluid. That's to say that the graft is failed. And one of the good policies is to look in the anterior aspect of the knee for the cyclope lesion, which should be a very prominent mass of fibrous tissue. But this is fat in the infrapatellar fossa, and this is ACL field graft. And here is in a CT scan of the shoulder, and you got an expansive lesion in the scapula.
ABC.
Yes, and this is a straightforward case of an aneurysmal bone cyst because of the multiple fluid levels in the lesion. And you know the sign which is known as the finger in a balloon. One of the best criteria of the aneurysmal bone cyst is you got normal bone, then sudden expansion, which looks like the finger in a balloon. And also the fluid levels is one of the criteria. Then here is
A lipoma arborescence.
yes, very good. And this is lipoma arborescens. They got a mass of a branching fatty tissue within the knee joint together with knee joint effusion. And here is an X-ray and a CT scan of the shoulder where you got a sclerotic or calcified lesion in the neck. What do you think?
Inchondroma.
Yes,
Inchondroma.
yes, and this is
Inchondroma?
a typical inchondroma in the long bones, frequently seen in the femur near the knee joint, but it can occur anywhere in the body and is diagnosed by the chondromatous calcification within the tumor itself, which may be seen in the plain film and also in the CT scan. And this is the spot diagnosis of
Osteochondroma.
yes, an osteochondroma or a cartilage capped exostosis, which is of two types, the sessile type and the pedunculated type, and this is the sessile type of the case. And this is an MRI axial image of the shoulder.
Reverse Bankart.
Yes, very good. And this is torn posterior labrum. And you see that the anterior labrum is intact. And this is the middle glenohumeral ligament. And this is the subscapularis tendon. And here you got rupture of the posterior labrum. If the labrum is still attached to the scapula, then you got a lesion which is maybe similar to the alapsa seen in the anterior labrum, but here you got the reverse of Bankert lesion, which means that you got rupture of the posterior labrum and you may got some indentation on the anteromedial aspect of the femur of the humeral head. Yes,
Dermatomyositis.
the answer is shown actually. I mean, here you got extensive calcification in the soft tissues around the fingers and also in the subcutaneous tissue, but the bones look normal and the joint spaces are maintained, and this is dermatomyositis. Dermatomyositis is an autoimmune inflammatory myositis affecting also the skin. And there are two types, the juvenile type, which is seen in children, and the adult type, which is seen in patients around the age of 50. And this is the classic appearance of the skin, which is looks dusky red with rashes, and in the X-rays, you got extensive subcutaneous calcification. There is a six-fold increased risk of malignancy in dermatomyositis, and the risk is evident whenever the patient is above 60 years. If he has dysphagia or accelerated onset of the disease or skin necrosis, like what you see here, that some of the parts of the skin are dead, and they got cutaneous vasculitis, and increase creatine kinase level, increase ESR and C-reactive protein level, interstitial lung disease, inflammatory arthropathy, and renal phenomena. All these are considered risks for the development of malignancy. Then this is an X-ray of the elbow joint of a pediatric patient.
Avulsion of polycranial fat. Bone.
Is avulsion fraction or
Bone.
what?
No, these are the non-united epiphyseal centers of
Above
the
this.
knee. This one,
Yes.
this belongs to the humerus, and the lesion is here. And
Epiphyseal
what
lesion?
is the name of this?
Epiphyseal lesion?
So, no, this is the capitulum, and there is a defect in the capitulum which is known as a osteochondral defect of the capitulum, which is analogous to osteochondritis dissecans of the knee. And we have two types of this lesion. One which affects most of the distal part of the humerus, and this one which is located only for the capitulum, and this is known as idiopathic capitulum osteonecrosis. This is a self-limiting disease and can heal spontaneously with some physical therapy.
Dr. Mamdouh, is it different from little league elbow?
Yes, little league elbow affects the medial epicondyle of the humerus, but this affects the capitulum of the humerus.
The variant of little league which affect capitulum isn't like it?
No, I don't know this variant actually. I know that little league affects the
Maybe.
apophysis, yes, medial apophysis of the humerus. Okay, let us move to this case, which is also is a spot diagnosis case.
Liquid degeneration of ECL? Of ECL?
Yes, this is mycoid degeneration, and many of the revisions, I insist to include a case like this because of the mistakes done in the diagnosis of such a lesion. And some may say that this is a sprain or degeneration or tear, but the accurate diagnosis is MECL, mycoid degeneration, and this is a classic appearance. And here is an MRI of the shoulder. Where is the lesion?
I think this reverse versus
Yes, and yes,
ellipsa, sorry.
لا here is prolapsa.
the reverse of ellipsa.
Prolapsa.
Yes, and then because of the displacement of the labrum posteriorly, but the periosteum is still intact, and this is the reverse of ellipsa, which is known as prolapsa. Very good. And what do you think this arrow points to?
I think this is a complete rupture of the infraspinatus.
Yes, very good. This is the spine of the scapula, and this is the characteristic inferior protrusion. Then this tendon will be the infraspinatus tendon, and you got high signal, and the tendon is not reaching the greater tuberosity, meaning that there is full thickness rupture of the infraspinatus tendon. Very good. And here is the X-ray of the hip joint in the frontal and the lateral view. What do you think? This is the CT scan of the same case.
Osteochondromatosis.
Yes, and this is synovial osteochondromatosis. You got too many loose bodies in the vicinity of the knee joint. They are clearly seen here in the plain film, but they are evident in the CT scan. This is synovial osteochondromatosis. And this is MRI of the wrist joint.
cartridge here.
Yes,
Tri-
this is
Triangular.
TC.
Triangular
fibrocartilage
ligament.
with extra position to this radio ulnar joint.
Yes, very good. And this is the extension of the fluid through the distal radioulnar joint, which is one of the signs of rupture of the triangular fibrocartilage. You are right. Then what do you think of this?
Bucket handle here of posterior horn of medial meniscus.
Okay, very good. You got attenuation of the posterior horn and you got the double BCL sign, which are diagnostic of bucket handle tear of the medial meniscus. Then this is a painful foot with no history of trauma.
No history of trauma.
Villonodular or synovitis.
Synovitis,
Giant cell.
giant cell synovitis, where?
Anterior to the medial.
Here.
No, anterior to the posterior tibial.
This image aims at this lesion. What do you think of this lesion? What is the name of this structure?
Plantar fibrosis. Plantar fibrosis.
No, this is just a plantar fasciitis. Plantar fibrosis, you got a mass, but here you got just thickening of the plantar fascia with abnormal signal in the T-weighted image, which is diagnostic of plantar fasciitis. اوكي تقريبا دكتور شريف احنا هنقف هنا ولا ايه؟ الو يا دكتور شريف.
ايوه تمام شغالين. حضرتك ممكن تعمل شير، معلش قطع.
طيب كده اهوت نرجع نكمل بقى صح؟
تمام.
اوكي صح كده؟ انت شايف
حضرتك يا دكتور.
طيب خلاص يبقى احنا خلصنا الحالة ديت اللي هي البلانتر فاشيتس، وبعدين ننتقل إلى this case with a spinal lesion, extensive spinal lesion in the dorsal spine, and this is T1, T2, and T1 post contrast.
TB.
Some axial images, and this is TB of course. You remember that TB of the spine, one of the signs is the extensive subligamentous spread, and this is a character in this case. And this is an CT scan of the
chondrosarcoma.
Yes, very
Chondrosarcoma.
good.
Yes.
This is chondrosarcoma because of the mass with the malignant criteria containing calcium. The possibility of chondrosarcoma should be considered. This is MRI of the shoulder and is not aiming for the supraspinatus tendon, but aiming for the inferior glenohumeral ligament, which is
Adhesive
Nervous.
capsulitis.
yes, adhesive capsulitis or a frozen shoulder because of the marked thickening of the inferior glenohumeral ligament and the tightness of the ligament. This is diagnostic of adhesive capsulitis. This patient is 35 years old with shoulder pain, and this is the X-ray showed a mixed lesion of osteolysis and osteosclerosis. And on MRI, then you got a marrow infiltrative lesion, which is a low signal in the T1 and high signal in the T2. The diagnosis is
It is a malignant lesion.
yes.
Leukemia, lymphoma.
Yes, very good.
Mm.
And this is lymphoma, and whenever you are confronted by a lesion which has the malignant criteria, and you think of three possibilities which are commonly put in the differential diagnosis. The three possibilities are number one, a primary bone tumor characteristic for this particular bone and the age of the patient. Number two is lymphoma. Number three is metastasis. Then whenever you look for this case and you see that the epiphysis has fused and this is an adult patient, so the possibility of osteosarcoma is not there, and also there is no significant perosteal reaction. Then you think of the other two possibilities, which are the lymphoma and the metastasis, and you may write this in the report as a differential diagnosis. What do you think?
Osteochondritis dissecans.
Yes, very good. And this is osteochondritis dissecans of the medial femoral condyle. This is the medial femoral because of the posterior cruciate ligament, and these are the signs of unstable fragment. Okay, this is an elbow axial and sagittal images.
I think this is a tear of the biceps.
Okay, the lesion is in the biceps actually, and this is the biceps which goes to the radius, and here you got abnormal signal within the terminal part of the biceps, and this is
Tendinosis, tendinosis.
yes, and this is biceps tendinosis or tenosynovitis. It's a good possibility, and the tendon is not yet torn, and you can see also that it is intact in the sagittal image.
Bone infarction.
Okay.
Bone
Yes, and this is medullary
infarction.
bone infarctions, which are a spot diagnosis, but actually many can be mistake this for a neoplasm, but you remember the Chinese figures. Okay, this is the Brod's abscess. The answer is there. And the Brod's abscess is an intraosseous abscess which is present in the metaphyses usually. And this is one of the good signs for the diagnosis of the Brod's abscess, which is known as the penumbra sign or the lucent line extending towards the growth plate, which is considered pathognomonic. This line, which connects the abscess to the physis or may cross the physis, is one of the supportive signs that this is Brod's abscess, and actually this is seen in cross imaging, not in the plain X-ray. This is an intraosseous abscess, is a form of subacute pyogenic osteomyelitis, usually seen in children, particularly in the metaphyses. Extension across the gross plate is not common, but if you see this sign, it's relatively pathognomonic for this particular lesion. Then this is MRI of the sacrum.
ABC.
Yes, and this is aneurysmal bone cyst because of the fluid levels, which are very characteristic of the aneurysmal bone cyst. This is MRI of the ankle. This is a normal for comparison, and this is where the pathology is.
Anterior tibio ulnar tear completely.
Is
Tibio ulnar is not present in the pathology.
Moses.
Yes. Yes, this is
tibiofibular.
the anterior
Anterior tibiofibular.
anterior tibiofibular ligament, which is commonly torn in the ankle joint. This is the normal ligament, and the two important signs of ligamentous rupture are the absence of the ligament and the fluid signal at its site. This is torn anterior tibiofibular ligament. This is the wrist joint, axial and
Fibrolipoma of median nerve.
Yes.
It was hamartoma of median nerve.
Hamartoma of the median nerve. The spaghetti sign is quite evident. And as I mentioned in the lecture, that I thought that this is a very rare condition, but it's frequently seen in the clinical practice.
Metastasis.
Yes, and this is an easy case where you got osteolytic lesion and another one, another one, another one, and you may got here the absent pedicle sign, and these are diagnostic of metastatic deposits. Then this patient had a ACL graft reconstruction, and he has persistent pain for 9 months.
Doctor, the lesion is around the screw or this is normal?
Yes,
Hmm.
yes, this is the lesion, and you remember that one of the complications of ACL reconstruction, yes, is development of a tunnel cyst, and this tunnel cyst means that there is an accumulation of fluid around the femoral tunnel or the tibial tunnel or both. And according to the literature, they said that this is not an indication to reopen or redo the case. This cyst will heal, and the screw is not يعني متلخلخ من مكانه. يعني the screw is good, and the tunnel cyst will heal spontaneously. But it is a known complication of ACL graft. This is MRI of the shoulder, and this is the acromic navicular joint, and this is the
articular tendinosis.
Yes, and this is articular surface tear of the supraspinatus tendon. The upper fibers are intact, the lower fibers are disrupted. And this is X-ray of the ankle joint.
Stone of the Achilles tendons.
Yeah, stoned Achilles tendon means that the Achilles tendon is made of bone, and this is a sequelae of chronic and neglected tear of the Achilles tendon.
Yes.
Yes, this is
necrotizing
infectious, exactly.
Yes, this is necrotizing fasciitis in the perineum, and one of the serious complications actually is the development of this disease, which is caused by a flesh-eating bacteria. And one of the good signs for the diagnosis is the presence of this air, and they call it sometimes gangrene of the perineum.
Dr. Mamdouh, in MRI for necrotizing fasciitis apart from air, what is the features we can say in MRI this is
Yes,
necrotizing fasciitis?
actually, MRI, if you do not feel that there is some air, although air is not a standard feature of this disease, but you got extensive inflammation like those seen in diabetics, where you got diffuse soft tissue edema and loss of the intermuscular and subcutaneous fat planes and abnormal increased signal in the T2 with heterogeneous enhancement after injection of contrast. But actually, we used to diagnose necrotizing fasciitis based on the presence of air on the in the affected soft tissues. And many times you can mistake air for any other lesion on MRI, but in the plain film and there's the CT scan, the diagnosis is somewhat easy.
Edmentoma, this is of tibia.
Yes, and this is a spot diagnosis lesion which is located in the anterior part of the tibia, and the tibial shaft is a little bit bowed. Then you know that adamantinoma does not occur, and it occurs only in two bones, the mandible and the tibia, and this is one of the classic appearances of adamantinoma.
It's tendinitis for Achilles tendon or what?
Yes, and this is Haglund syndrome. You got the three components of the syndrome: Achilles tendinosis and the fluid signal anterior to the Achilles tendon in the retrocalcaneal bursa, and the subcutaneous fluid signal as well. And these are the three components of Haglund syndrome.
Simple process with ankle fracture.
Yes,
Pathological fracture.
yes,
Yes.
and this is simple bone cyst with pathological fracture. And you know that the proximal femur and the proximal humerus are the most common sites for simple bone cyst. And if you see a benign looking cystic lesion in these two particular locations, you should think first in the simple bone cyst. And then the simple bone cyst may be liable for fracture. And in such a fracture, you got the bone fragment falls down within the cyst to the bottom. And this is known as the fallen fragment sign, which indicates that this cyst is a unilocular cyst. It does not contain any septation. So the fracture fragment can easily fallen down into the bottom of the cyst. But you should remember one important sign, that is whenever the simple bone cyst is fractured and you got hemorrhage inside the cyst, and this hemorrhage will form a fluid level inside the cyst, then on MRI, if you see a fluid level, you may mistake this cyst for an aneurysmal bone cyst. But be careful in the diagnosis. Whenever you see a lesion like this, aneurysmal bone cyst contain the fluid levels without a fracture, but the simple bone cyst contains the fluid level with a fracture, a pathological fracture. This is one of the important differentiating points. Then this is an MRI of the knee, and you got a classic lesion in the epiphysis, which is,
Chondroblastoma.
Giant cell.
yes, yes, this is chondroblastoma, which is, I think that this is the only epiphyseal lesion which is seen before the closure of the physis, and the lesion is mostly confined to the epiphysis. Sometimes it may cross the physis into the epiphysis if it is a little bit large. This is the MRI of the wrist joint, and the triangular fibrocartilage is
Okay.
intact.
Yes.
Yeah.
scapholunate ligament, there is a tear.
Yes, very good. And this is the scapholunate ligament tear. And you got the scapholunate ligament is pyramidal in shape, and this is abnormal signal within the ligament itself, but the scapholunate interval is still intact.
Transient osteoporosis.
Yes, migratory osteoporosis. And you see there was some edema here, and after 2 months it's big. After 3 months it has been migrated to the opposite condyle. Then if you see the edema is migrating from a joint to another, from a condyle to another, and this is migratory osteoporosis. If it is persistent in the same condyle, and this is regional osteoporosis.
Non-ossifying fibroma.
Fibroma, non-ossifying fibroma.
Yeah, or
Fibrous cortical
Focal-
defect. Fibrous cortical
yes,
defect.
and the fibrous cortical bone defect or non-ossifying fibroma. Actually, we cannot discriminate between both, but sometimes I said that if the lesion does not deform the bone or associated with some expansion, you may call it fibrous cortical bone defect. If it is sizable and cause some expansion of the bone, you may call it non-ossifying fibroma.
Aneurysmal bone cyst.
Aneurysmal cyst.
Yes, aneurysmal bone cyst, and this is a bubbly lesion with internal septations in the distal part of the tibia, which is a common location for aneurysmal bone cyst. Elbow joint. This is the
Tennis elbow.
It is
tennis elbow.
lateral epicondylitis,
and,
yes.
This is lateral
Epicondylitis.
epicondylitis. And you see abnormal signal in the common flexor or extensor tendon, and you got extensor, yes, and the signal either is associated with partial or complete tear, or even only a single abnormal signal in the tendon. These are also are called the lateral epicondylitis. And this is T1, T2 or stir, and this is T1 fat sat post contrast showing this lesion. The lesion is the cortical based and does not cause expansion of the bone, and the patient is young. Then he diagnosed this as fibrous cortical bone defect or non-ossifying fibroma. Actually, the diagnosis of fibrous lesions by MRI is very difficult. Since you suppose that this is a fibrous tumor, it should show low signal in the T2 also, and it does not enhance. But there are extreme variabilities in the fibrous lesions by MRI. They are easily diagnosed by X-ray and CT, but you may have some difficulties diagnosing this by MRI.
Dr. Mamdouh, how can we differentiate it from a chondromyxoid fibroma?
And actually, the chondromyxoid fibroma is not one of the frequent lesions we can see in the clinical practice, but it's usually associated with some expansion of the bone and some sclerosis of its cortex. But this lesion is based to the cortex. It does not cause any expansion of the bone, or even if it causes some slight expansion of the bone, you need to consider these two possibilities. but the lesions that are not frequently seen in the clinical practice usually need the biopsy to reach the diagnosis, and the chondromyxoid fibroma is one of these lesions.
See,
Okay. Then this is X-ray MRI T1 and T2.
Sympathetic reflex.
Yes, this is the diabetic foot, you may call this, because of the osteomyelitis. How do you know that this is osteomyelitis? Bone marrow edema, low signal fit T1, high signal fit T2, obliteration of the joints, erosive changes in the bones, and some abscesses in the soft tissues. Actually, for the diagnosis of Charcot joint, you should have some more destructive changes and the disorganization of the joint, but the diabetic foot frequently pass to the Charcot joint. And the Charcot joint is a manifestation of three items that are ischemia, infection, and the loss of sensation or disturbance of the sensation, and is commonly seen in diabetic patients with the destructive changes in the affected joint, and these destructive changes are usually referred to by the 5 Ds or the 6 Ds, as you know, and these are the causes. Diabetes is in the top, and some of the neurological abnormalities like syringomyelia, spinal dystrophism, spinal trauma, and so on. And this is an example of Charcot joint in the hip. It is common in the foot actually, but it can be seen in any joint, in the knee, in the hip, in the elbow, and any joint in the body may show this extensive, destructive, and disorganizational changes.
Chordoma or metastasis.
Okay, then I expected you to say chordoma or chondrosarcoma, actually. And metastatic deposits actually do not contain calcium unless they are coming from a bone form, a bone tumor like osteosarcoma and chondrosarcoma. But the classic appearance or the classic position of the lesion in the midline affecting the sacrum, and is if you look carefully, you can see that this sacroiliac joint is intact and this sacroiliac joint is affected by the tumor. Then if we suppose that this lesion is arising from the sacroiliac joint, then the possibility of chondrosarcoma will be the most likely. But if this lesion is midline destroying the sacrum, then you can suspect the possibility of chordoma. Okay, and this is MRI of the ankle joint.
Coalition.
Coalition between
navicular and
Between
calcaneus.
calcaneus and cuboid.
This is the calcaneus,
Cuboid.
and this is the cuboid, and you got
Ah.
the joint is intact. But if you look carefully and you see masses of synovium, or let's say synovial hypertrophy along the posterior
Pigmented
aspect of the
edematous
joint,
or what?
and a pigmented villonodular will show low signal in the T2 weighted image. And if you look carefully, and you can see that this synovitis extends to the retrocalcanean bursa and causes some erosions on the Achilles tendon.
Rheumatoid.
Yes, and this is rheumatoid ankle. Synovitis is one of the signs of joint infection, and hypertrophic synovitis is one of the criteria of rheumatoid disease, especially in this particular area. But if you do not notice these signs, you can say just this is synovitis, and it is considered the right answer.
Avascular necrosis of scaphoid.
Void.
Yes, this is vascular necrosis of the scaphoid, and we have two types of vascular necrosis. The vascular necrosis secondary to trauma, and this vascular necrosis without trauma, which is known as Brizier disease. And this Brizier disease has two types. The type 1 is complete involvement of the scaphoid, and type 2 is partial involvement of the scaphoid gut area, and the remaining part of the scaphoid is good. And this Brizier disease is explained in the lecture of hematological bone diseases.
multiple bone
Then, yes, we've got diagnosis of multiple
multiple bone
bone
infarction.
infarctions. Yes, and next is
Synovial
synovial osteochondromatosis.
yes, synovial osteochondromatosis by MRI, and you got too many loose bodies within the shoulder joint representing synovial osteochondromatosis.
Is what
This is
This is the elbow joint, and you got extensive low signal lesions within the
villonodular
capsule.
pigmented villonodular.
There are two, yes, there are two possibilities here: the hemophilic arthropathy and the pigmented villonodular synovitis. Actually, these two images are not enough to select one of the conditions, but you should have the post-contrast image. And in pigmented villonodular synovitis, the lesions will enhance, but in
Hemophilia,
hemophilic
not
arthropathy,
enhancing.
the lesions will not enhance. Then, if you have a lesion like this, and this is for the differential diagnosis between both hemophilic arthropathy and pigmented villonodular synovitis. Yes,
Osteosarcoma.
and spot classic appearance of an osteosarcoma with sun ray speculations and the sclerotic texture, the site of the lesion, or are in the favor of synovial osteosarcoma, of an osteosarcoma of the fibula.
cyst of the disc meniscus.
Yes, and
meniscus.
this meniscus is torn, and you got a cystic lesion filled by fluid at the base of the torn meniscus. This is known as para meniscal cyst.
Avascular necrosis of the third metatarsal.
Vascular necrosis اسمها سكودي فرايبرج ديزيز. Freiberg disease, yes.
And this is Freiberg disease, osteonecrosis
Of the head of the
head.
yes.
Usually the third one, but maybe also the second also.
Osteochondroma.
لا دي اوستيوكوندروساركوما انتم.
Yes, no. This is an osteochondroma. In order to diagnose chondrosarcoma, you should see destructive changes in the surface of the osteochondroma, and you may got also some soft tissue tumefaction, which is associated with. If you do not see this, and you cannot say that this is malignant degeneration. This is just an osteochondroma, the pedunculated type.
Carpal syndrome. Carpal syndrome.
Carpal syndrome due to
fibromatosis of the median nerve.
Of the median nerve. This is in the axial image, and then the previous one was in the sagittal image. What do you think? This is the tibia.
Tegmentinoma also?
No. Long disease in a long bone.
Fibrous dysplasia.
Yes, and this is fibrous dysplasia. Long disease in a long bone is a fibrous dysplasia. Very good. MRI of the knee in coronal image.
The lesion in the medial collateral ligament.
Yes, very
Collateral
good.
ligament.
And this is medial collateral ligament tear, grade 3.
This is maybe focal or femoral deficiency.
No, the femur is good bilaterally, but the disease is here.
Blunt disease.
Yes, and this is blunt tibia or blunt disease, which may be unilateral or bilateral with flattening and peaking of the tibial metaphysis together with affection of the tibial epiphysis. And this is the gross disturbance, the blunt disease, the gross disturbance at the proximal tibia. It involves the medial epiphyseal plate, the epiphysis, and the metaphysis. This is the area of affection, resulting in medial angulation and the varus deformity, as well as internal rotation of the tibia. There are two forms, the infantile form, which occurs before the age of 3 years, which is more common, and the juvenile form, which occurs around the 11 years of age. The infantile form is bilateral in about 80% of the cases. The adolescent form is unilateral in about 80% of the cases. And the disease is diagnosed very easily by the plain film, and you got the prominent metaphyseal peak of the tibia, and you got a small size of the medial part of the tibial epiphysis, leading to inward diversion of the leg, which is known as the varus deformity. And this is one of the types of avascular necrosis occurring all over the body. And sometimes you may need to measure the angle and to know where this angle between the first of all, you draw a line along the shaft of the tibia, then you put a perpendicular line on it, and you measure the angle between this line and the surface of the affected metaphysis. Then this is once more a lesion in the fibula, which is a classic 4.
Aneurysmal bone cyst. Aneurysmal bone
Yes,
cyst.
aneurysmal bone cyst with multiple fluid levels. And here is an MRI of the knee with a lesion in
The infrapatellar tendon. Patellar tendon.
patellar
Tendinosis.
Out tendinosis, very good. And this is a lesion in the calcaneus.
Cyst, temple bone cyst.
Yes, temple bone cyst, very good. And this is the hand of a patient with
sarcoidosis.
No. No. This is hemolytic anemia, and you remember in the lecture of hemolytic bone, of hematological bone diseases, thalassemia and hemolytic anemia, and any form of hemolytic anemia will present itself in the skeleton by marrow hyperplasia. And the marrow hyperplasia means expansion of the bone and increase in the trabecular pattern. This hand is classic for thalassemia or any type of hemolytic anemia.
It is chondroblastoma.
Yes, chondroblastoma in the epiphysis of the tibia, classic appearance with some faint calcification inside.
Xanthoma of Achilles tendon. Xanthoma of Achilles tendon.
Very good. Yes, this is the xanthoma of the Achilles tendon. The Achilles tendon is hugely enlarged, and it is of dark signal. This condition may be unilateral or bilateral, and there is accumulation of lipid-laden macrophages and inflammatory cells, as well as giant cells and the cholesterol deposition in the tissues. And this is one of the warning marks for cardiac or coronary heart disease, because the deposition of cholesterol is there and also in the coronary vessels. This condition may be bilateral, as you can see in this case, and can be also unilateral. And the tendon is markedly expanded or enlarged with more or less dark or striated signal, as you can see here in this example.
دكتور ممدوح
نعم.
can we take a short break عشان اللي عاوز يصلي العصر.
And actually, there are remaining 2 minutes
Okay,
for
good.
the Zoom to be shut down. Then we'll make use of these 2 minutes and to go.
What's the tear of the Achilles?
Tear of Achilles tendon?
Tear of the partial, because the anterior fibers are intact and then the posterior fibers are torn.
Intercondylar cyst, intercondylar cyst.
Yes, intercondylar cyst, intercondylar ganglion cyst, cruciate ligament cyst, or all these the same diagnoses. And here you see fluid collection around the greater tuberosity, and this is one of the bursa. This is greater trochanteric bursa, and there is also a less trochanteric and iliopubis, and so on. And here you can see a form of carpal tunnel syndrome because of the abnormal signal of the median nerve, and the cause is fracture of the hook of the hamate. And you see that there is a fracture surrounded by bone marrow edema of the very characteristic bone, which is the hamate bone. And you see the hook that is fractured, which is one of the causes of carpal tunnel syndrome.
Inchondroma.
Inchondroma, yes, inchondroma. Yeah.
Avascular necrosis of leonate. Avascular necrosis of leonate.
Yes, this is leonate avascular necrosis with a sclerotic appearance of the leonate bone without fragmentation.
Diabetic foot necrosis.
Diabetic foot.
Diabetic foot because of the air in the tissues and also the erosive changes in the bone.